Good morning. I am Dr. Arash Jawanbakht. I'm a psychiatrist, and I'm Director of Stress, Trauma, and Anxiety Research Clinic at Wayne State University, Department of Psychiatry. So today, my intention from this talk basically is to provide a clinically relevant overview of PTSD from the neurobiology to treatment and overcoming challenges of working. I'm sorry, I'm a bit short of breath, I was running. Overcoming the challenges of working with special civilian populations, including refugees and first responders. So one of the methods that I will briefly discuss here is a patent under Wayne State University, and I'm the inventor, and these are our sources of funding. So at Stress, Trauma, and Anxiety Research Clinic, which I want to call STARC, I founded this clinic with an intention of bringing research insight to clinical work and do research that is clinically relevant. And in that light, we treat patients, and majority of these patients are people who have gone through some sort of trauma, whether civilians, refugees, survivors of torture, survivors of human trafficking, and first responders. And then on the research side, we are looking at the neurobiology of trauma and how it impacts the brain and the body. We use neuroimaging, look at inflammatory markers, autonomic responses, epigenetics, and we have a large study of looking at the course of illness in Syrian and Iraqi refugees resettled in Michigan that I will mention a little bit in this talk. We also, because we want research to help clinic, have a focus on improving treatment methods that we have, whether it's trying to understand the neurobiology of treatment and how it changes the brain, or utilizing telepsychiatry or other advanced technologies, or more cost-effective ways of helping the person with trauma, which can help a lot, such as dance and art and movement therapies, and that I will talk about later. I also work a lot with the media in terms of public education, which I think is a very important area of our work too, especially in this day and age of misinformation, to keep the public informed about what is true. So the first question about post-traumatic stress disorder is, why is it important? Everybody says my disease is important or more important than your disease. Before I came here, my wife is from marketing, and she was like, from the name of the conference, it sounds like there's going to be a lot of anxious and depressed people there. So my anxiety is better than your depression. Why? Because prevalence is very high. In the urban population, up to 90% have been exposed to at least one criterion A trauma. And by trauma, you know what we are talking about. Trauma is not a difficult breakup. Trauma that we are talking about is assault, injury, rape, shooting, witnessing murder, horribly traumatic experiences. Prevalence is about 8% in adults, and you can see prevalence in other ages. Compare this with 1% as the prevalence of schizophrenia. And then there are special groups in whom prevalence is much higher. In combat-exposed veterans, it can be up to 30%. In first responders, up to 20%. Refugees, survivors of torture, across different studies, somewhere between 30 to 80%, pass the diagnostic threshold for PTSD. And what is important, especially for a clinically oriented session like this, is despite the way sometimes it is treated in research, PTSD, or post-traumatic stress disorder, is not a plus-minus illness. It's not like COVID that you either have it or you don't have it. It's not an on and off condition, because we have a range of symptoms. Those who work in clinic are very familiar. We have a range of symptoms from 0% to 100% of all the symptoms someone can have from sustaining a traumatic experience. We draw an imaginary line, let's say at 70%, and we say whoever's above it, we call it PTSD, right? Full diagnostic. And sometimes, simplistically, we say, okay, 69 or 68 or 65 is resilient, which doesn't make a lot of sense, because you just have one or two symptoms less than the other person. Dysfunction and distress may still be there, or even worse, and these symptoms with a little bit of support or a little bit of stress can oscillate and go up and down of this line. And actually, in the research study with refugees that I mentioned, we are looking at the longitudinal changes of these symptoms and what are the neurobiological and environmental correlates of these changes. So looking at the PTSD as a clinician, as the consequence of trauma as a clinician this way, we sometimes don't necessarily care much about, oh, do you fill all the criteria, otherwise just go home, you're good. And then, I always tell my residents that there are two symptoms which have to be, there are two criteria which have to be at the end of every single DSM diagnosis, otherwise we do not make the diagnosis. Dysfunction, distress. And that is why we are treating, what we are treating. We treat dysfunction and distress. We do not treat flashbacks, we do not treat nightmares, we do not treat depression. We treat what is making the patient dysfunctional or causing them a lot of distress. And I will later talk about how that can help us basically navigate what is the best or what is the priority in treatments that we are presenting to our patients. Then there are the comorbidities. I myself have rarely seen someone with chronic PTSD who did not also have depression, did not feel full criteria for major depressive disorder. And imagine how debilitating each of these are and how they will be together. MDD by itself doesn't allow the person to go out and venture out and interact with the society. Top that with continuous fear of something going bad and flashbacks and nightmares and being on edge. Substance anxiety disorder, substance use. I always say some dance to remember, some dance to forget. Some use the drugs for this reason and some use it for that reason. Some people use it for reducing their basically self-medicating. And then there are a variety of medical conditions that can be worsened and have an increased chance of development with people in people with PTSD. Obesity, metabolic syndrome, cardiovascular disease, pain. And actually in our study with the refugees, we just found in a relatively young, healthy group of refugees, which did not have medical diagnosis, their severity of PTSD symptoms directly correlated with the way they perceive their own health. Like, how do you perceive your health? Excellent, terrible. The worse the PTSD symptoms, the worse they perceive their physical health. And on top of that, interestingly, we threw in another question, which was, how tough was the whole experience? Just one question. That also very highly predicted. So basically, these three variables were very well connected, which does make sense because we have one system processing the data here. And this system may process the data coming from my body, from my mind, and from outside in a relevant and similar way. And PTSD is also one of those conditions that is easy to miss. Trauma is easy to miss for a variety of reasons. One reason is that there's not much of training, at least in the residency trainings that I've been exposed to. The amount of training residents get about treatment of schizophrenia and bipolar disorder is a lot more than what they learn about PTSD. So a lot of people don't know, and all of us, when we don't know, we are less comfortable with it, we brush it under the rug. That's what I do with substances, because that's something that I don't know well, right? And we do not often ask about trauma. At meetings with residents, often I ask, how many of you ask your patients about their sex life, and how many ask about trauma? Similarly, very low number of people, because number one, you're shy about it a little bit, it feels a difficult conversation, and you don't know what to do with it if the patient said something, right? And patients don't want to talk about it also because it's a very painful issue to share with. I've had patients who, for the first time after 2-3 decades, told me about a rape that happened during the college that let them leave that city and never get married after that. And they were in treatment for OCD for years. And then the other thing is that when we become subspecialized, we become too our diagnosis oriented. Like, as an anxiety and trauma expert, I often miss on asking about substance use. And imagine those working with chronically psychotic patients, how often do we ask about trauma from those people? Not much. But who's more vulnerable to trauma than a chronically psychotically ill with limited cognitive function and resources, homeless on the streets of an urban area? And then there are tough people like first responders that I will talk later who find it more difficult to talk due to a multiple variety of reasons. When it comes to the prevalence of impact when someone is exposed to trauma and what % of them may develop that full-blown PTSD we talked about earlier, it seems like, as you can see here, the more the source of the trauma is human and intentional, the more the damage is to us. We are social creatures, we are social beings, and what another human does to us intentionally, besides ruining the trust, interhuman trust, can do a lot more damage compared to, let's say, a natural disaster, where potentially in those situations is also a kind of a tribal cohesion where all of us get together against this natural disaster or the Russian army. When it comes to the PTSD definition, we don't have to go through the DSM criteria. We all know there's trauma, and as I mentioned, a lot of times our patients perceive trauma as like, oh, I had a difficult breakup or I had a fight with my mom. And because they don't know that what we define as trauma, so we have to have an agreement with them. And the way I asked from my patients about trauma is, what is the worst, most horrible, most traumatic, terrible thing that has ever happened in your life? If they said, oh, once, I don't know, again, example of breakup, I had a breakup where my heart was really broken, no abuse. Well, I'm thinking probably less chance, but if they said, okay, do you want me to tell you about when I was 5 years old and my father was raping me, or when I was shot at the age of 14, or this or that, then we know that, okay, there's a ton of trauma there. And trauma could be happening to myself or others. So indirect exposure to trauma is very common among refugees and first responders. Intrusiveness symptoms, we all know about them. Intrusive memories keep coming. You push them away, they keep coming back. Nightmares, flashbacks. When it comes to flashbacks, sometimes they may be mixed with hallucinations. Because a flashback is a perceptual experience. I see the things when I'm triggered. I hear the sounds. I feel the touch. I smell the smell, especially in veterans and victims of rape. And that is a real perceptual experience, and it doesn't mean the person is psychotic. Avoiding anything that is reminded of trauma, and the negative cognition and mood and hyperarousal, the person is always on edge. They're always, basically the brain is in fight and flight mode. The whole idea is I don't want this to happen to me again, so I go to a mode that I'm constantly screening for danger. I'm ready to run or attack, hence aggression, hence violence, and I cannot focus. My attention is away from anything that could be good or could be neutral. My attention is only here. Let's say if I had and this all have evolutionary perspectives. I always say to understand fear, we have to understand the context in which it evolved. The fear when I came here this morning, if I was shy of public speaking, my heart would be pounding in my chest, but this is very unhelpful. But 80,000 years ago, if I was among a group of my tribe mates and they didn't like me, chances were that one of us would be dead in a matter of minutes, right? So that's why the heart is pounding, preparing me for that fight and flight. So here again, this whole system is ready to run away or attack. So now I'm going to have a very short tour of the neurobiology, but with a clinical perspective. I don't want to get you bored about details of what happens in the brain and the body, but from a clinical perspective, because it not only helps us in the treatment, but also helps us in explaining to the patient what's happening. Because I really firmly believe that level of insight that the patient gains help a lot to gain control over what's happening. If a firefighter on a mission is having a panic attack and they don't know why they have a panic attack, that's a different story. Then they know, okay, this is the origin and source, and I'm not going to die with this panic attack. So, very simple. How do we learn fear? Like all other animals, we learn through associative learning, basically what we call conditioning, right? I'm a little kid, this vicious German Shepherd attacks me, and I learned dogs are dangerous. The Pavlovian fear condition, right? And depending on how serious, how dangerous the attack was, and how vulnerable or prone to fear and anxiety I may become afraid of German Shepherds, big dogs, all fluffy animals, small dogs, everything, right? So we generalize that fear learning. We can also learn from our tribe mates. Like, it would be stupid for us 50,000 years ago for each of us to be attacked by that vicious animal. If it attacked one of us, then the rest of us would learn to avoid the animal. So we learn. And how does that happen in trauma? Exposure, indirect exposure. Indirect exposure, whether I'm a first responder who went to a scene of a shooting, or I was caught in the middle of the shooting, or I am a refugee coming from a war-torn area. We can also be told what is scary and what is dangerous. The way we are primed about it before the trauma can also have an impact on how we create a meaning for the experience that we had. Of course, this also was helpful. 100,000 years ago, the elderly told us, don't go to that side of the woods, there is a predator there, we would listen. But now they tell us, oh, don't go towards that race or ethnic group of people, they are dangerous, and we'll listen to them. That's a kind of a loophole being abused now. We also learn safety in similar ways, which is interesting. We can be exposed to Jasper and Dobby and Haley, who are very kind and nice and friendly dogs, and gradually that fear memory extinguishes, and I learn that we are safe here, right? And that's how exposure therapy works for us. But in human work, we do never throw a patient in a room with a dog and close the door on them and say, okay, I'll come back an hour later. So we also have the social learning of fear, safety. So we can see, oh, these other kids are having fun with Jasper, so he should be fine. That's how the therapist walks in and says, okay, we are good, we are safe. Shows it with the behavior, with their approach to the scare, or basically demeanor that they are not looking scared. And we can be told, which is what we talk about in therapy, in cognitive forms of therapy or CPT. So we are contextual animals. What does that mean? It means that your emotional reaction to this view, if you were there, would be a lot different than your emotional reaction to this. In the first one, probably you would panic and try to run away. In the second one, you would be curious about this cute animal. Because in the second one, there are contextual cues. The bars, the people laughing, the sign that says zoo, it's all the information in your physical and emotional and social context that tells you this is a safe animal. And that is important because context plays an important role in therapy and in development of PTSD that I will talk about a little bit later. So now that we did this like a little intro about how we learn things, now what happens in PTSD is, well, associative fear learning happens, right? I am assaulted by a soldier, and I'm afraid of soldiers. I've had refugees who, they see a cop here on the street, they panic, they freak out. They don't want to, they don't think the cop is dangerous, but that's the animal reaction, associative learning. And then we overgeneralize. That is what's not great in PTSD, because cringing to a sound of a gunshot makes sense. That's not abnormal. But cringing to a sound of a slamming door or 4th of July is something abnormal that we do not want to see in the person. And that's how generalization is what bothers the people with PTSD. Combat veteran might have left Iraq or Afghanistan and they're not there anymore. But there are a lot of cues here that remind them of what was there that can cause the problem with the anxiety or avoidance of limiting their ability to function. So when we talked about context, it seems like in PTSD brain, contextual processing is also a little bit off. It cannot see the cue that I'm exposed to is in a safe context, not in that dangerous context that I was in. For example, this is an IED. So a veteran on the streets of Iraq seeing this scene would reasonably be anxious, a little bit scared, right? But a lot of those who work with combat veterans know a lot of them get scared of roadkill because this resembles that, but the brain doesn't differentiate that. This bag of garbage on the side of street of Iraq and this bag of garbage on the street side in Denver are very different contexts. That contextual processing is not happening. And in a sense, if we wanted to have a wider view of context, wider definition of context, because most of research of context has been done on physical and social context. We also have temporal context, time, right? A lot of those who work in the clinic are familiar with the patients on an anniversary of event getting worse. Knowing there are patients who during the time of the day that the bad thing happened to them cannot go out. And there might be some mismatch in anxiety and trauma where the temporal context is not processed well. What do I mean by this? What I mean is that a memory is something that happened there and then. But a memory in a person, in a lot of us, and in a person with trauma can trigger a panic attack, as if the memory is right here, as if the memory is happening now. So it seems like there's part of this whole system that doesn't differentiate between here and there, now and there and then, which I believe part of the therapy is basically contextualization of these memories. We keep talking about the memories, then we come back to here and now. We see the therapist. The therapist is basically the anchor in here and now. We go back to the memories, come here, back to the memories, come here, and potentially part of the memories being put in the context is done the way we do the therapy. And that's what in the psychoanalysis they call primitive process thinking, that they believe unconscious brain is timeless. It doesn't have a perception of time. So maybe that's the pathological unconscious brain that doesn't have it. So, looking briefly about the brain, very briefly, and if it gets boring, please tell me to fast forward. So, don't look at these little pieces of amygdala, look at it whole as the one thing. Here also, this yellow piece in the temporal lobe. Amygdala's job, we all know, is salience detection. Basically, anytime I'm exposed to something, an object, amygdala has to decide, should I eat it, should I have sex with it, should I attack it, or should I run away from it? And based on the determination, let's say now we are talking about fear, amygdala says, oh, I saw a scary face, we have to be prepared for fight and flight. Sends the system to the motor apparatus through a striatum, preparing us, the whole motor system and motor memory for fight and flight, and then activating the HPA axis, which leads to activation of the sympathetic nervous system that we will talk about later. And then there is hippocampus sitting next to amygdala. And I explain these to the patients when we talk about it, maybe in a little bit more simple language. Hippocampus and amygdala are very, very closely tied and knit together. And hippocampus, we all know about its role in memory and learning, and every day helps us learn new things, but it also helps us learn about fear and safety. The other thing, the other role that hippocampus has, along with prefrontal cortex, is processing the context. So amygdala sees the snake, freaks out. Hippocampus, prefrontal cortex, they read, there's a sign that says pet snake, or the friend tells you this is a pet snake, or you have the other evidence in the context, and then you calm down. Basically, they send inhibitory messages to amygdala to slow it down. And then we have insula here. Specifically, the interior parts of insula are highly involved in interoception, perception and awareness of what is coming from inside of me. Whether it's the chest or stomach tightness that I'm feeling because I'm anxious right now, or whether the awareness of being anxious. So, in a very brief summary, you could already imagine what we have in PTSD happening in the brain. Increased activation in amygdala, increased activation in insula because I'm very anxious and I feel this anxiety, and then decreased activation and volume in those areas that regulate amygdala. So we talk about the prefrontal cortex has got too good of a reputation, in my opinion, because we always talk about it as a rational, logical, reasonable part of the brain that decides to shut down stupid amygdala reactions, but a lot of times it works the other way. If right now somebody walked in this room and said, everybody, there's a gunman on the loose, how would you feel? What is causing that? That's some cognitive instruction that came in through those higher cortical areas. So it can also trigger fear, and it can be involved in the meaning that we create for the experiences that can lead to increasing or decreasing the anxiety that we are experiencing. And by that role, it can be used and abused in right and wrong ways of creating fears of safe things or helping us not be afraid of safe things. So very quickly, there have been some functional studies of each of these areas if you want to look at some more details, which basically amygdala, any picture, any sound, any noise, any smell that resembles the trauma, or even a scared human face, because scared faces and angry faces automatically trigger our amygdala response. Trigger a larger response in people with PTSD. And then with the hippocampus, same. Hippocampus is shrunk, it's smaller, the architecture is not as beautiful as it used to be, and there is reduction in the activation of hippocampus, including in context processing and reducing amygdala response. Increased activation of insular activity, which correlates with symptom severity. And with the prefrontal cortices, again, we have reduced activation, reduced volume in the medial prefrontal cortex, and it's negatively correlated with the symptom severity. What's interesting here is the last line, that when you do provide therapy, treatment, so these areas of the brain are plastic, they can get better. And these are great news for the patients whom traditionally have learned that if you have a mental illness, you're doomed for the rest of your life. So when we talk about the body, we talked about HP axis, right? And then the sympathetic nervous system sending all the signals throughout the body, the traditional fight and flight system getting activated. Pupils dilate when we go to fight, right? Pupils get dilated, stomach stops working, bladder stops working, heart is pounding faster, heart pounding is also stronger, blood is going more to the muscles and less to the skin, and then coagulatory pathways getting stronger, readying us for creating blood clots and inflammation also being on ready. All makes sense, all is reasonable, all is good for someone who's going to get potentially harmed in a fight and flight with a predator or with a person from another tribe. But the problem is that with the condition with PTSD, after you remove the person from the context of trauma, these responses continue. They don't stop. And they continue on over a person's life. And these are some evidences from studies of ourselves and other labs. What's interesting is that we can put a couple of wires on your fingers and hook them to a phone. And these wires basically create a very weak electrical current between the two electrodes, which goes through the moisture of skin. And the more moist the skin, the more the conductance. And that moisture of skin is very closely correlated with autonomic or sympathetic activity. So we can dynamically see how autonomic activity is working. I've even used it in exposure therapy, like the patient sees how the response is going up, and then through the layers of exposure gradually comes down. So this is how lie detectors work, that the skin conductance is part of them. So Tanya Jovanovic's team had basically used this in the ER to look at the autonomic reactivity to trauma, basically recalling the trauma story. And they saw that the higher the response, the higher symptoms of PTSD 6 months later. So they might have a predictive value. I'm going up. In our cohort data, with the refugee children, Syrian and Iraqi refugee children, we found these skin conductance responses correlate with the number of trauma exposures, the number of traumatic events. They correlate with the severity of trauma symptoms. And they also specifically correlate with re-experiencing symptoms, which makes sense. You're asking someone to recall a memory, and we see an increased response. Well, if you have a tendency to have high re-experiencing symptoms of PTSD, you will see the same response. So, and we're hoping this paper by Lana Grasser, my PhD student, Dr. Grasser now, will come out soon. So, overall, what's the outcome? In a patient with PTSD, there's increased baseline heart rate, there's increased chance of high blood pressure, increased startle response, difficulties with sleep because the sympathetic nervous system is working constantly and nonstop. And this puts all the pressure. It's like you are you're driving your car all the time, 100 miles per hour, no rest. There's evidence, a lot of evidence coming out about the continuation of presence of inflammation in people with PTSD. Increased metabolic disease and obesity we talked, chronic pain, these are all the long-term consequences. And as I mentioned earlier, feeling less healthy from our study, that basically people said the degree they found themselves physically healthy highly correlated in an inverse way with the amount of symptoms they had in terms of PTSD. So quickly, because I don't know what percent of audience are prescribers and what percent are non-prescribers, I will just very quickly go through both types of the treatments that work and don't work, and then move on to special populations, which are the refugees and the first responders. And of course, in general, basically how to overcome the challenges of treatment. So what makes my job easy in an anxiety and trauma clinic is that when I want to prescribe medications, I just have one option from the class of the medications: SSRIs and SNRIs. I mean, we have a lot of them, but in terms of the class, that's what we have. And a lot of times when used correctly, they work. They work very well. And we can talk about it a little bit later. When it comes to evidence-based therapies, we have exposure-based therapies, we have cognitive processing therapy, and EMDR. In terms of exposure therapy, a lot of us have heard of prolonged exposure, or PE, which is basically having the patient go through the trauma memory over and over and over and over and over and over until the emotional intensity is dissociated from the trauma memory. It's an effective treatment. The difficulty with PE is that a lot of people don't want to do it. And those who enter, a lot of them drop out. So at the end of the day, you may have 20–30% of people who did it in the clinical trials. And so in that sense, you have limited ability to convince people to do it. But there's also other aspects of exposure therapy, which I am more interested in, which is a combat veteran who comes here with PTSD will not go back to the streets of Iraq. Chances are very low. But that combat veteran here with the PTSD cannot go to a grocery store here, cannot go to a restaurant, cannot go to their kids' games. So exposure to safe civilian environments the person is avoiding due to the trauma is much easier, more achievable, more acceptable by the patient, and I think has a good impact on patient's functionality. Because at the end of the day, what we are treating is dysfunction and distress. And cognitive processing therapy, basically talking about the meaning that I have created about the trauma and how these perceptions and how these new schemas I've created because of the trauma. Oh, I'm a bad person, this has happened to me, or God doesn't like me anymore, or what is happening? Because in general, we are creatures of meaning, even if there is a meaningless world around us. You all have had patients with trauma whose question is, why me? And that why me ends up with, because we are raised, most of us, with a perception of a kind of a fairness and meaningfulness in the way things happen in the world. More so as scientists. And then the person is, why did this happen to me? Why am I? Is it because God doesn't like me, or the universe doesn't like me, or I'm a weak person, or I did something wrong? And then people start thinking about what was that I did wrong. It could be guilt, it could be shame. In different kinds of people shows itself in different ways. In a combat veteran may show it, oh, I missed this thing and my colleague died. In a victim of rape, especially with some pressure from the society, oh, this is because of what I wore or what I said or where I went. And part of the treatment in my work is to tell them, listen, the only reason this happened to you was that you were in a wrong place at the wrong time with that predator, with that person, with that event. It could have happened to anyone else. Sometimes things don't have a meaning. And then we have to work on what is the more, but then you want to work within the context of the patient's ideology of how this can make sense to them. If you're talking to an atheist versus if you're talking to a devout Christian, you're working with different systems. And then you have to put yourself aside. I don't care about what I'm thinking unless my patient is delusional. This is about how they make sense of this story. Not a very relevant story, but I had a patient from a very conservative Christian background. She decided that she wants to be bisexual. And she was extremely depressed. I mean, actually, first I found she's extremely depressed. Guidelines would say, oh, relapse of MDE, give her a higher dose of your medication. Well, we talked more and we found that she wants to be bisexual, very conservative family. The devil really hate it. And as we were talking, what she said was, my grandmother would say, I'll go to hell. I'm not religious, I'm not Christian, I'm spiritual. But the immediate answer that came to my mind was, what would Jesus say? And her immediate answer, no thinking, was, he wouldn't care. Well, how about you go with what Jesus would think than your grandmother's? And that worked. I'm not saying that it's always that easy, but basically working within patients' structure of thinking to help them understand and make sense of things that have happened or are happening. So in case of the acute trauma, the best thing we can do is supportive therapy. There have been a lot of things suggested. It seems that what works is that that person needs a supportive, caring, safe environment to help them basically figure out what's happening. Well, you need a warm blanket. I was talking to a reporter from Finland about what's happening in Ukraine, and she was asking, what should these drivers do with the people that they're bringing? They're all, I will just show some anecdotes. They are very stressed. My answer was a blanket, maybe a sandwich, some water, making them feel safe. And if they want to talk about it, let them talk about it, but you never force them to talk about it. So prazosin has been, some say it works, some studies, some say it doesn't work, some larger studies have been inconclusive. So if someone has nightmare that doesn't respond to their original medication, I do try prazosin. And then there are things that may not work. Forced trauma debriefing, forcing the patient to talk about trauma right after the trauma. We don't do that. It may consolidate trauma memories. Propranolol has shown good stuff in the lab, not much coming out of the clinic. Benzodiazepines, I call them Hotel California because you can check out anytime you want. You can never leave. When you have a patient on benzos, it's very hard to let them go. And they also have a chance of dependence. And when it comes to combining therapy and medications, benzos can limit or impair learning. I mean, because we have a window of arousal for learning, right? The higher beyond that window of arousal, the person is so panicky that they cannot even think what you're saying in therapy. Below it, they're so bored or sleepy or not cognitively prepared to learn. So we have to keep them within that within that optimal window of anxiety or arousal, and benzos can inhibit that or basically block the learning. So overall, they're not recommended. Antipsychotics, inconsistent data, not sure if they're working. A couple of trials have shown they may help as an adjunct. But the big problem with antipsychotics is that we talked about high chance of metabolic syndrome, obesity, diabetes in these people, so we have to be very careful there. And unfortunately, sadly, sometimes in our business, we forget that for psychiatrists, that we also are physicians. As a physician, I am responsible for a person's whole health, not just symptoms of what comes out of their head. For anti-epileptic data, there's not much. So VA DoD guideline, this is a cool guideline that you can find for free online, and they have done a comprehensive review of what works and what doesn't work and what may or may not work. So they don't recommend antipsychotics and epileptics. There are some new drugs that have been discussed and explored. They're more in the research area at this time. I wouldn't be very comfortable using them in the clinic, especially with the potential long-term risks that we may have. And I've said it before. We don't want to end up with what we did with the benzodiazepines and opioids. So we got to be careful, and especially when it comes to MDMA. It has become the way the media have spun it is, oh, you just take MDMA, your PTSD goes away. They just totally forget about the assisted therapy part of it, that you need to have a trained, skilled person, which I don't know how many we have, to do it next to you. That's the clinical trial that showed the efficacy. So this is the guideline that we talked about. So when we want to do exposure therapy works very well. Effective gold standard treatment, but the problem we have is, how can you create those exposure scenarios? Let's say I came to your office and I'm afraid of dogs. Where's the dog? Where's the cat? Where's the spider? Where's the crowd? Where's the gun? So you have to become creative, or you have to show me pictures, or you have to just tell me go home and do things, or we do what I call, hey, what's up therapy. Just sit down and talk about things for like 80 sessions. So virtual reality and augmented reality are some technologies that can allow and help with this. Virtual reality technologies have been around for a while. What they do is that they create the whole context of the environment, mostly in combat veterans. Basically, you wear the goggles, you're on the streets of Iraq, and then it's a visual way of prolonged exposure therapy. Exposure happens to those scenarios, and they have had good results for those people who can do the PEP. It helps. In our lab, we are working on a patent method of utilizing augmented reality, which is the next wave of a human-computer interactive technology. which means you see Shantanu, my student, is wearing the goggles. These goggles are see-through, like these glasses. So if I was wearing the goggles, I would see all of you here. And then there's a spider on that wall. So we mix reality and the unreal, and that helps me be able to walk and go to that spider. And the spider will crawl from the wall and come to here. And so we started this. We started with spiders, of course. That's the easiest one. We ran a clinical trial for spiders, fear of spiders. As you can see, I will show you a little video, actually. In less than 1 hour, one session therapy, everybody was able to touch a real-life tarantula or the tank containing tarantula after the treatment. The clinical trials published. So then we added dogs and snakes to basically have an OCD for the phobias. Then we started an app. Basically, during the pandemic, we wanted to see if we can move it to the app space where you can have your app at home and your therapist be in the clinic. So we said, okay, let's do some practice. And we created a free app. You can download it for free. Pandemic Stress Tips. Basically, we'll have a 3D version of me. Not that I'm very arrogant, but we wanted to see if we can create a human that we know. And a few dogs around me in your living room, and I will be talking to you about how to overcome the stress of pandemic stress tips. But then we are moving it up for another project we have for first responders, PTSD, that we want to create human encounter scenarios, because as we talked earlier, for a lot of people with PTSD, including first responders, they don't want to be around the crowd because this brain, if a cop or first responder enters this room, the first thing they check is the exits. And they sit there with the back to the corner where they can watch everybody and the exit. So they're very uncomfortable. They don't want anyone behind them. So because this brain has to screen for danger all the time. So what we do here is create incremental social situations which are common, universally, globally avoided by people with PTSD. Let's say a party or a gathering or a restaurant, or which can happen right here. Or a CPR, which is tough for first responders. I will show you a little tiny video here of this technology. So Sunday morning, I will talk, I'll have a talk about this, and I will explain a lot about how it works. So as you can see, the goggles she's wearing shows the they're see-through. And this is what I see. As soon as the patient wears the goggles, I see a 3D view of their surrounding environment. That yellow spot is where the patient is looking at, and I can see where the patient is, where they're looking at, and then just go on my drop-down menus, choose a spider, snake, whatever I need, and choose the type, the color, the size, and place it in the patient's environment. And the patient can go close, get away from them, interact with them. And this is after treatment. And this woman did it in less than 1 hour. I'm going to move a little bit faster. We have added fear of dogs. And the good thing is that you can have a variety of whatever type you want to have. You don't have to just go bring your Labrador from the home here. You can have all kinds and breeds of dogs that you want at different sizes. So, but when it comes to the PTSD, this is what we are working on. It's very difficult. I'm learning that programming each scenario takes 3-4 months. But this is on the bottom corner, you see the person wearing the goggles. The big picture is what I see as a therapist, and the top right is what they see. Ooh, let me come back here. So basically, this is a party that we gradually add more and more people and noise, and the patient can walk around them. And these things feel so real that I, as the creator of this thing, when we were testing it, actually it was not in a good shape. The people were standing a foot above the ground, and everybody was too tall, and they were not even blinking. But when I'm walking, I had to walk not to bump into them, because that gives a very realistic feel. So anyways, therapy is very important. Why is it important? Because unfortunately, we sometimes fall from this side of the roof, sometimes from the other side of the roof. And sometimes we want to throw a medication at everything. We cannot throw medication at traumatic memories, avoidance, social consequences, issues that are ongoing in a person's life. So therapy is extremely important, the first line, and I'm the pill pusher guy who tells you that the therapy is important. Of course, medications help a lot also. So, now shifting gears towards talking about refugees and first responders. So, or overall special populations of civilians who have their own unique exposure to trauma. So refugees and survivors of torture across the studies, 30 to 80% PTSD full force. Law enforcement officers, firefighters, 80% of police officers have seen dead bodies or severely assaulted victims over the past year. And this is part of their day-to-day job. Survivors of human trafficking, and in these groups, the exposure to trauma is chronic, it's ongoing. It's not just, I had a terrible car accident and now I go back to my safe home. When it comes to refugees, life of a refugee is not just, so one thing I hate about my job when I give these talks is that we talk about percentages and numbers and 1 in 4 people, 3%, 10%, 30%. We turn it into a concept. And it's hard to connect emotionally with a concept. The reality of a refugee life is that, let's talk about what's happening in Ukraine. So people were living their lives. All of a sudden, it could be us, right? All of a sudden, there are extreme loud explosions happening. Every day they are telling that there are sirens going on. We have to go live in the basement of this. Well, this hotel has a nice basement. We could be in a terrible basement. We don't have electricity, we don't have food, we don't have water. In Syria, you wouldn't know who in this hour, the person in charge of this territory is your enemy or your friend. They're killing you or not, kidnapping your kid and asking for money or not. And this goes on and on and on and on and on. And then you go out to get bread and you see dead, mutilated bodies on the street. And those who are lucky enough to leave their families and their belongings and their house and those who love, they're dead or alive, they end up in a camp which is extremely cluttered, extremely packed, and again, lack of resources, ton of uncertainty. Imagine you and I are not certain about our job tomorrow. How stressful is it? Now, imagine that we are sitting in a third country. We don't know where we would be shipped and when, and how much do we even know the language or culture of that country we're arriving at? No. And when you go there, it's not that you will be the same doctor so-and-so you were. Now you're nobody. And with very limited resources. So this is the life of refugees. I talked to a reporter. I wrote a piece about Ukrainian trauma a couple of weeks ago, led to a few interviews. And one of the reporters shared some stories from, actually the top story is from an acquaintance. This is from Ukraine. The other two are from drivers bringing Ukrainian refugees to Finland. So when we talk about refugees, we are talking about such experiences. We launched a study in the state of Michigan recently, working with basically refugees, looking at the impact of exposure to war trauma among Syrian and Iraqi refugees in southeast Michigan, which initially was based off of my startup fund and all volunteer work, and then we ended up getting some good funds from the NICHD to follow through and look at the longitudinal course of the illness. Everybody on our team was volunteer refugees themselves on the ground, refugee doctors, some of them migrant. And in the course of less than a short course, we could recruit a lot of people because we recruited through a community, nonprofit community service that was basically doing health screening for them. So they would develop a good relationship with their doctor, and the doctor would introduce them to us so they would answer the questions. So I will just go fast through them because I have a lot to talk about. So what is important in this graph is that all these refugees who left Syria 2 or 3 years ago, 5% of them had a previous mental health diagnosis. What does that mean? That means that nobody looked at it, right? And this is what we found. 30% of adults, regardless of gender and sex, screen positive for PTSD, having all the criteria. Nearly 50% high anxiety and depression. very high. We talked about 8% lifetime for the civilians in America. This is comparable with lifetime prevalence with Vietnam War veterans. So extremely high level of impact. When it comes to comorbidity, I talked earlier about how high the comorbidities. Depression, about 80% also of those with PTSD also had depression and anxiety. When it comes to children, we didn't have much high of a percentage of PTSD, which may mean that the parents kind of buffered them against the impact of trauma, or a kid may not be cognitively cohesive and developed enough to create a meaning for the story, which leads to the PTSD and just raw anxiety. Nearly 80% separation anxiety. High anxiety and separation anxiety. Why separation anxiety in a kid? Because if I were a kid and outside was extremely dangerous, well, it would make sense for me to not want to leave my parents' side because they know what is safe and what is not better than me. We have heard stories of Ukrainian kids don't wanting to leave the subway now because they don't feel safe out there alone. And then that in the host countries, this leads to a lot of problems that we have been talking to teachers that kids don't want to go to school. It's not that they hate this school, they're terrified to go to school. And very quick, actually on Saturday we have a symposium on refugees, and in that symposium we will talk more about this data, but basically symptoms do not change over time. And actually for some people who have been basically impacted by human causes of trauma, the symptoms may even worsen 2 years later. Same for anxiety. Symptoms by themselves don't go away, so people need help. It's not that, oh, you left the trauma environment, now you're good. No, that doesn't work. So we have also worked with some creative ways of helping the refugees overcome their trauma experiences, because one problem we had was that, in general, we don't have a lot of trauma experts, people who can treat trauma and PTSD. And then among those, finding someone or some people who are also culturally and language informed is harder. So, and some of these traditional treatments, whether therapy or pharmacotherapy, may not be accepted due to stigma, due to other cultural differences. So that time, as a clinician, I was feeling bad that, okay, we have all these cool data, but what are we doing for them? It was a time that Lana Grasser became a PhD student of mine, and she is a dancer, and Holly Finn Callaghan, who is a faculty at Wayne State University, came and said, oh, we do art therapy, how about we help them? So we put together like a group of everything, the volunteers, and a nonprofit organization would bring the a kid and a mom, because we know separation anxiety, to our clinics, and we would offer dance and movement therapy and art therapies, and we measured the impact. We also did mindful yoga for moms. What's very cool is that dropout was very low compared to some other ways of addressing trauma. And we had a good amount of decline in the symptoms of PTSD on the left side, and anxiety for the dance and movement therapy, and had the similar findings in art therapy. So basically, an art or dance therapist whose time is much less costly than mine and can see multiple people in one setting than me, and then can transfer information and the trainings to them that they can use at home by themselves, would help a lot there. Because when these guys came to me and said, we want to do this, a big question, my knee-jerk reaction as hardcore researcher was, I don't know. And you hear that answer a lot of times, right? And then, oh, is it going to work? Or this is voodoo science. So, but no, I said, well, let's do and measure. And we measured, and the data shows these things are working. Adherence is good, and they're reducing the symptoms. And what now the team is doing is basically expanding to schools in Metro Detroit, and now with the changes in the pandemic and the Zoom, everything can be done over the Zoom. And they're working, basically Lana and her team and others go to a place where a hotel where there are Afghan refugees, and they present these treatments. And we now also have been talking to Ukraine to basically create a kind of a training from psychiatric to psychological to other aspects of the providers there who can who can deliver the treatment. That does not got anywhere yet, but we have started the conversations. And in that line, I've also tried to work basically helping the public have a better understanding of what refugees go through. So these are the articles that if you ever needed to share with the public or patients as refugees or knowing of refugees, you could share. So the next population that I work with is first responders. And I put this picture here intentionally because we don't see this. These are cops and firefighters and EMS people in Dearborn after a car accident. They're moving that person's car out of the way. They didn't have to do this. So first responders, that includes a large group of people, police, firefighters, EMS, dispatchers, and correction officers have a very tough life. Dispatchers, who could imagine a dispatcher has a tough life? But we listened to a call where a kid called a dispatcher and said, like an 8-year-old kid, I don't want to lie, 8, 10, I don't remember exact age. Something happened last night. Since last night, me and my younger sibling have been hiding under the bed. What happened? Somebody shot both my parents. There's blood there. They're laying in their blood downstairs. So the dispatcher relays this call to the cops to go there and see what's happening, and then dispatcher has to pick up the phone to listen to the next story without knowing what happened here. And then those cops go there and see what we just talked about. Firefighters also go, EMS also go, and this is what happens to them every day. They have a very tough job. And what makes it more complicated is that for a combat veteran, the veteran is in Iraq, is in Afghanistan, is in Germany, and then whatever happened there, they come back here and the context is very different. For a cop or a firefighter, where they work, where they live, is the same thing. At the same restaurant that they may want to go with their family to eat if they're working in a small town, they might have arrested someone, or they might have done a CPR on someone. And the exposure is chronic and chronic and chronic. Exposure is basically part of their job, which affects also their social life because they do not have a clear schedule, right? It's hard to have they have shifts, like firefighters have 24-hour shifts. And then also, if you have been traumatized, they don't want to be around people. They don't want to go to your kid's game. And these examples I'm using are real examples I've heard from the first responders. They feel family doesn't understand. Quote, I want to come home after a very tough run that I pulled out a person out of a burning car to have half hour to myself to just sit down here, be alone. And these learned occupational behaviors leak into their normal life. Like I always, when you see a cop or a firefighter as a patient, say, oh, so when you go to a restaurant, you sit with your back to a corner next to the exit where you can see everybody. I'll say yes. This becomes normal life behavior in these people. And job requires being in charge and autonomous and suppressing emotion, which becomes difficult when emotions become overwhelming. And you have to have quick responses. We have done ride-alongs with these people. Like I was at the fire station, and the one cool thing about fire culture is food. Every time one person makes a whole meal and everybody eats, and I'm waiting for everybody to come sit, and the person next to me says, you gotta eat, because there may be a run now. And yeah, there was a run 2 minutes later, so from sitting here waiting for your parasympathetic system for eating and listening to this other person joking, you're in an ambulance which is moving very fast to a car accident where someone might have died, or it could just be like some ignorant civilian decided that, oh, I want to go to the hospital in an ambulance. And I say ignorant because we saw a lot of people who nothing happened to them. It was like a tiny bumper to bumper, and they're like, oh, I want to go to the hospital, and they were on the phone all the time, and they were on the stretcher in the ambulance. And back-to-back diverse tasks. These tasks continuously change. A cop told me once, when you are pulled over, on the other side of the window for you, there is an annoyance. When I pull over someone, for me on the other side of the window, there could be a gun. Unpredictability, a lot of it. And then, of course, COVID made it worse. This is some quotes from, some of you might have heard there was a shooting in Oxford High School in Michigan. One of the students just brought a gun to the school and started killing people. A parent of one of the kids there was on, and I will not say what was his first responder role, but this person was just heard the call. And he runs, and he's driving fast in the mud and in the sand, and thinking about his child, trying to call his wife to see where his own child in that school is. And he walks in, of course, all the scenes, blood, kids, and that nothing I had planned out in my head happened. And I'm hesitant to tell people where I come from because they will keep asking and that will bring through the memories. And there's consistent and frequent reminders everywhere you go, including the media. But he doesn't tell people he's from the Oxford town or what his job is there, because then people want him to tell them about it and what he thinks about it. And you know how hard it is to talk about trauma. And this was a man sitting in front of me crying. Stigma is a big problem when it comes to first responders. And that stigma has multiple components. They have a fear. They have a fear of loss of job or part of job. They may have to be removed from job or be moved to a desk job, or my identity. But for a lot of them, their identity is what they're doing. So that also affects their identity. They're worried about what their colleagues think about them. They think, oh, you're weak. Why didn't it affect me the way it affected you? And fear of loss of control, which is hard specifically for a group of people whose job requires being in control. Having a panic attack sitting next to your ambulance is a terrifying experience for these people. Lack of trust. By their job, they are trained not to trust easily, and they have difficulty trusting. A lack of cultural understanding by the providers. I started working with them. I'm an academic psychiatrist. I had an idea that they have seen fire. I didn't know why would a police officer who keeps pulling people over get traumatized? And, well, I dealt with them in a different way. We did some ride-alongs with these people. I started learning about their work and job, and now it's very different. The way I work with these people is very different. And the way they trust me is also very different. So they have this issue that the providers do not understand them well. And then there's a balance between the trauma consequences. And earlier I missed to mention, trauma not always lead to PTSD. Trauma can lead to depression, trauma can lead to anxiety, trauma can lead to adjustment disorder, whatever. Trauma impact on their job and being able to go back to work or not, part is what we decide. And I wrote this with one of my students about, it was a journal, AMA Journal of Ethics, about, they asked us, okay, if a doctor and a cop, the doctor has to decide when the cop has to go back to work. And this was during the Black Lives Matter movements and all the difficulties on both sides of the story and for the cops. So we basically wrote this piece, and the conclusion, bottom line was, which is what I do in my life, I never do workman's comp evaluations, even for my patients. I see a lot of cops and firefighters, but they've asked me repeatedly, I said, well, then how can this person trust me to tell me everything? So go have another psychiatrist do that evaluation. That's at least what I believe. Other people do both. So we talked about work and life environment overlapping with these people. Both of these scenes could be a crime scene for a cop or a firefighter, or could be going out with their family, or being at the kids' game. And then there is a personal link to the experiences. I've repeatedly, over and over, heard from firefighters, cops, EMS, that we had to do CPR on a child the age of my own kid, or this kid overdosed at the age of my kid. Like I had people who for 20 years, they have seen all the crap. And let me just quickly say what they see. Just a cop. They see domestic abuse, They see dead bodies, they see rotting bodies, they see decapitated heads, depending on where they are. I mean, in Ann Arbor versus Detroit is a very different story where I come from. But still, both of them see a lot of these things. They see overdoses, they see car accidents. Everywhere firefighters go, cops also go with them. So they might have been shot at. They might have seen dead bodies who were shot at. They might have had one of their colleagues die on a mission, whether it was a car accident or a shooting, or they see other people die, or they might have killed someone. And that killing someone might have been justified or not, and even if it is justified, it's something that they carry for the rest of their lives, and they hate it. So when it comes in terms of relatability, people who have for decades seen all of it, one day they see some young man looking like their child, and that's the day that hits them hard, when it is relatable. And the meanings that they create about it, so we talked about it earlier. What did I do wrong? What have I done? And always we have to remind them, listen, hindsight is 20/20. Guilt and shame always comes with trauma. And these are like big focuses of treatment to remove, to let the patient, free the patient from these chains, for him to be able to go back to the functioning. And associated fear learning, fear conditioning. I had a patient who, I had a SWAT team member that I was working with, and one thing I love about this population when you work with them is that they're disciplined, and they want to get better, and they listen, if you understand the language. So he wanted to work out, and every time he went on the treadmill, he would feel very anxious when his heart rate would go. And we talked, and what we learned was that when you are on a mission, chasing a criminal as a US Marshal or a SWAT team member that this guy was, your heart is pounding very fast, but you're in a very dangerous situation. So the brain has associated this heart pounding with danger. What we did do was the same thing we always do. So now we have insight, the cognitive insight, then do exposure therapy. So go on a treadmill for a heart rate of 100, just keep it there. And then next time up at 210, 100 and whatever. So this is what he sent me the last time. As you can see, 140 beats per hour, beats per minute, sorry, not hour. And he was very proud. And then there's always anger as another side of the fear that happens in the relationship with the family, in like being easily startled, easily angered. So this is a project we have started in our department at Wayne State University, and I'm hoping to finish in like 10 minutes, and then less than 10 minutes, and then open for questions. So we basically got some funds from the state of Michigan to help our first responders. And what we do here is that we have put together a team of first responders and ourselves. We had to learn from them, about them. As I said, we did ride along with them. We went and learned what they do, what's their culture. The police culture is different than the fire culture, is different than dispatcher culture, than veteran culture, although they have a lot of overlaps. Working on training, educational material, videos, vignettes, working on peer support groups, that has been working very well, because these are the people who understand you and you trust them. It's not that those peers do therapy. No, those peers kind of, when you come back from a tough run, I've seen these groups. They just talk, okay, what happened? What are the difficult things? Oh, when I did this, I did this. It's not like a forced debriefing of like bringing up the trauma memories. And then, more importantly, they can detect when the person needs to see someone like me and do the referral, and then they transfer the report because of the trust issue. And then we are working also on putting together a network of culturally informed experts. So I also wrote a couple of pieces for the Associated Press conversation, the aching blue and the aching red for the fire, and basically teaching the public about the traumatic experience, the difficulties of jobs of these people. So, the barriers to and challenges in treatment. So we know there's lack of access to skilled therapists. Well, thanks to COVID, now insurances allow us to do telemedicine, so we can have access across the board. And part of the difficulty with access was if the provider is far from you, now you're losing half of the day of your work. You have to think about the gas money, transportation, and especially for less financially fortunate people. And then the child care. So now the services can be delivered more easily. and trust, especially with, as I mentioned, in this group, and also another group which has difficulty with trust is survivors of human trafficking, understandably so. Stigma, we talked about stigma, cultural barriers when it comes to refugees, somatization. For a lot of people, when culturally it is not accepted to be mentally aching, then you start having back pain and you start having a headache, which you given when we find there's a depression or anxiety or trauma and you treat that source, a lot of these pains go away. Family interferences, especially with refugee populations. I've had mothers saying, oh no, my kid is not crazy, I don't want him to have medications. And well, sometimes we just picked up the phone and called mom while the patient was with me, and we basically explaining, and then that same mom became an ally in enforcing the medication utilization. We talked about first responders. There's some blame on us as providers. So the example I have is, so a few years ago, nationally, the producers of National Geographic came to do a report because they were writing, and this movie is coming soon. I'm going to advertise for it because it's a good one, and I don't have any benefit in it. The Elephant and the Grass. It's about South Sudanese refugees. These guys came to interview me because I work with refugees as a kind of an expert there. And then I said, well, if you want to give an idea, if you want your American audience to relate to the trauma of a Sudanese refugee, let's also talk about childhood trauma in America. We brought one of our colleagues, Tanya Jovanovic, to talk about it. And then I said, let's talk also to one of my cops. So this guy sat down, and the first thing he said was, I was dealing with these symptoms for a long time. I saw a few providers, and they told me this is what it is, and you have to live with it. And when I saw this guy, and I didn't remember any of this, he said at the end of the interview, he smiled and said, we're going to fix it. And when I heard we're going to fix it, I felt my feet coat, and I stood up, and I fought it, and we fixed it. So sometimes, unfortunately, we are so psychopathology focused that we burn a label on a patient's forehead that for the rest of your life you are this diagnosis, and you got to live with this, and it's not going to get better, and this is your new identity. And when you do this, of course there's a backlash. Of course there's denial. The person doesn't want this, doesn't want a new bad identity. So what I do is a lot of times, this is an illness that we can change. There's a lot we can do, and there's a lot you can do. For a lot of people, they can be cured, and I'm not lying. And for a lot of people, can be managed very well. So this is not new you. This is something that even if some symptoms remain, the same way we do, what do we do with pain that doesn't go away with all the treatments we do? You build a life around the pain. You do not make pain your identity, which unfortunately becomes for some patients. You see, they come in and all they're talking about that pain. Everything in their life is that pain. That's horrible. So we want them to be able to see, especially for first responders, this is something aside. You are not a broken person. We're going to fix this. So, ways of overcoming stigma. Using biological medical model works a lot. When we talk to people, first of all, when I offer a medication, I talked about the elephant in the room in the beginning. I said, listen, I'm a psychiatrist, but I love psychotherapy. I'm not a pill pusher. These medications are not going to change you, who you are, not going to change the way you're thinking. They're not going to change you to a zombie. They are not addictive. And we are not marrying you to the medication. If you didn't like it, we'll stop it, because if it is not helping you, you and I are wasting our time and you're wasting your money. So we figured that out in the beginning, especially in a situation where control is important. The patient wants to have a sense of control. And then explaining the biology of how it works gives a person a somatic insight that helps a lot. Helps a lot. We have always historically needed this kind of insight that it is not me, it is something else. Whether that something else was the gods, or the demons, or the uterus, or the liver, or the amygdala. We need that. And explaining basically to the person, okay, now that you're having a panic, this is what's happening, this is the fight and flight response, and this and that, and the panic is not going to kill you, and it's going to go away after a few minutes. Psychoeducation in a more biological language, and parallels you make between, so people say, oh, I don't want to be on the medication for the rest of my life. I say, I don't want to be on medications ever. But if a medication can help you be more functional. Just taking a pill make you be more functional and avoid those long-term consequences like high blood pressure and diabetes and this and that, sign me up. And then, so if I'm always taking this medication, it means I'm dependent on it. The answer is if you are taking a blood pressure medication and you stop the blood pressure medication and your blood pressure goes up, it doesn't mean that you're dependent on the medication. It means that you stop the treatment. So build alliance with the family, give them control and give them time. There have been times that patients came in and said, no, I don't want medications. Go do your therapy, and they were referred by the therapist. Go do therapy for 4 to 6 more weeks. If it worked, awesome. If it didn't, then come back and we can reconsider. Or, hey, this is the medication I'm thinking it may help. Let's try it. If you liked it, awesome. If you didn't like it, we have 2 million other options. You are the one who's taking it. You can stop it anytime you want. And be open to other options. Sometimes people have other options that is working for them. A lot of things are placebo effect. And why would you not like the placebo effect? And focus on what they want to change. This is very important. Sometimes we get into a struggle and fight and challenge of egos about what I want and what you want. At the end of the day, this is a client who came, who wants some pain to be resolved, and that pain is a priority for them. Well, if that pain is like I want my Xanax, no, of course not. But we can align the priorities, and focusing on function and distress versus focusing on symptoms helps a lot in building that alliance. With the Middle Eastern people, I'm Iranian, I'm from Middle East myself. So my experience has been medications always have all the side effects. And I don't know, is it metabolic, is it cultural, is it placebo, is it because all the drugs have been tested in other races and not in the Middle East? So every time I work with a Middle Eastern person, whether a refugee or not, I start the smallest dose, like 12.5 milligrams of sertraline, and see what happens. Because they may have a lot of side effects. And if they have, I'm open to changing. And at the end of the day, we may end up with a small dose of buspirone, and it works, or a small dose of a benzodiazepine. Make medications your ally. Explain how it works. That really works when you explain for the patient. And you don't say, for 3 weeks, this is not going to do nothing. No, why would I kill the placebo effect? I say it may take a couple of weeks to kick in fully, and I've started you on a low dose. And so if you didn't see magic, don't be disappointed. Later, we can up the dose. And again, we talked about the options and sense of control. Don't give up on medications quickly. I've seen patients who have tried 15 other different medications before they came to me. Well, give it some time. Give it a full good dose before you give up. And try to address multiple symptoms with the medication. I use side effects as my allies. If I have a patient who has depression and PTSD and insomnia, I start with trazodone. So a lot of people tolerate a full dose of trazodone, which helps with anxiety, depression, and insomnia. If they also cannot eat, well, I give them, and they've been losing weight, I give them mirtazapine. So use the side effects as an ally. If you have a depressed patient who doesn't have energy, well, we have bupropion. We can give that medication. And that also gives them options. So again, control. Share the control with the patient. Listen, I have 2 options based on the symptoms you have told me. Both of them do the same for your anxiety and for your depression. One of them will help you sleep better. The other one may help you with your back pain. Duloxetine. You choose. So the patient feels they have an agency here and a choice. And psychologically speaking, medication is a transitional object, correct? So what is a transitional object? Winnicott's concept that when the baby starts leaving the mother, grabs the teddy bear and takes with him or her, which is a reminder of the mother, and gives them a sense of peace. So the pill that I have inside of the patient is my transitional object, a piece of me. Whatever the patient feels about me affects the way that pill does in them. So report, and a good relationship. And again, we gotta know the limitations of medications. We should stop being stupid trying to fix everything with medications. If a patient is being beaten up by their spouse every day, increasing the dose of my SSRI is not gonna do it. A lot of things are besides what we do: diet, lifestyle, social life, exercise. So I wrote this piece a while ago about basically practical ways of being able to live the way we evolved to live, to basically be healthier mentally and physically. And some of these issues I've discussed. Because and at the end of the day, if my life is waking up in a sad room, overweight, eating, getting drive-through garbage food, go sit at a desk, hate, then come back and get drive-through garbage food, lay on the couch, and watch garbage cable news for 5 hours, which is telling me the whole world is collapsing. What is a fluoxetine gonna do? I don't know. So our patients need also a life, and they need something to live for, and that is that. And a happy patient, my wife always says, a happy wife, a happy life, a happy patient, a happy provider. So if you can help your patient be happier, well, that works. Exercise, I use it a lot, and I promise this is the last one. Exercise, regular cardio especially, increases BDNF in the brain, positively affects the hippocampal architecture, which is helpful in emotion regulation. It's kind of exposure therapy to physical symptoms of anxiety. When you're working out, your heart is pounding faster, you're sweaty, you're short of breath. All of these are symptoms of anxiety. That's like social effects. You meet people, you run into some other person, you're walking your dog and you meet your neighbor, and then it turns to a date, or like going out for dinners. A lot of things, sunshine, this is like common sense issues and things that work. And this research shows it does have an effect on anxiety. With this other study about basically paper about practical ways of learning and doing exercise, something that is doable. Because a lot of times patients say, oh, I cannot go 1 hour to the gym, 1 hour on the treadmill and come back. Of course, but there are ways you can do it. And majority of my patients do work out to some degree. And I promise I didn't choose this picture, the editor chose it. I'm not that arrogant. Thank you so much, and I'm sorry I took a little bit longer, and I'm open to any question, comment, advice, suggestion. Thank you.